on the answer key. Just don't look right now. You want to remember those drugs that you can use for oral MRSA treatment, right? In my handout, there was a little kind of review. It says drugs for MRSA, keep in mind which are IV and which are PO. And the handout that I gave you for skin infections, there's a separate handout, summarizes it really well. So if you want to study, that is a good kind of handout to study this, right? So there's only a few that can be given for oral MRSA treatment, and then we also want to differentiate between community and hospital-acquired MRSA, right? So this is a few drugs, not many. So let's think about the options. Linezolid can be given, comes in both oral and IV formulation, excellent oral bioavailability and covers MRSA. B, vancomycin also comes in an oral formulation and covers MRSA, so you can just switch to this with the same dose. Keflex is an oral first generation cephalosporin that covers MRSA, so you can switch to that, or you can give any of the carbapenems as well. So what is correct here? Let's start with D. Is D correct? Why not?
Any.
They don't treat MRSA. Right. None of the carbapenems. Okay. What about C, Keflex? Does it treat MRSA? No. So we have two excluded. What about B? No. Why not? You're right. You're correct. But why not?
Oral is only for C.
Exactly. Thank you for saying this. Oral is only for C. diff. You cannot use it for MRSA, right? So what is the correct answer automatically? A, right. A is correct. This is oral and IV. It's excellent oral bioavailability. So we have the same 1-to-1 conversion in dose, and it covers MRSA. So that would be a good option for this patient. Now, if it were community-acquired MRSA, right, and they had started, let's say, vancomycin, but it turns out it's community-acquired MRSA, and the organism, the community-acquired MRSA, is susceptible to the other drugs. I'm not telling you right now which they are, but the different. So what are the options for community-acquired MRSA? Two options. What is it? Bactrim, right? Excellent. And? Clindamycin, not so good, but there's another one. Doxycycline, right. Okay, so if I had this case with community-acquired MRSA, and I said the organism is susceptible to all antibiotics that could be given for community-acquired MRSA, then Bactrim and doxycycline would be great options, right? For hospital-acquired MRSA, only linezolid, or titizolid. Okay, so now we have another patient, 50-year-old male, is coming with a severe UTI. The patient has a catheter in place, and which is a high risk factor for UTIs, and he has also had several UTIs in the past. The team suspect the patient UTI is due to Pseudomonas, and they would like to treat him empirically. Which of the following antibiotics would be the most appropriate to choose in this patient? So the first thing we need to think about, which of those drugs has activity against Pseudomonas, or which does not? Which does not? Let's start with E. Does Bactrim treat Pseudomonas? Have you ever heard this? No. What about ceftriaxone? No. What about tigecycline? No, that's the exception. It's a broad spectrum drug for all kinds of organisms, MRSA and gram-negatives and positives and anaerobes, but no MRSA and no Pseudomonas. So that's not an option. What about Cipro? Is it a good one? Fluoroquinolones, guys? Yes, it is. What about moxifloxacin? Not so good, right? No. So it would be ciprofloxacin. So when you study the quinolones, think about the role of cipro and levo and moxifloxacin. These are the only three I would hold you responsible, right? What is special about these three in terms of their treatment, their coverage, right? So very important, yes. So ciprofloxacin would be the best option here. Another thing is moxifloxacin does also not go through the renal route, right? It's hepatically metabolized. So that would be a good choice in somebody who has a UTI. You want a drug that concentrates in the urine. So list our antibodies that have Pseudomonas activity. So going beyond the first exam, just go to the antibody that we covered in the second, for the second exam. So after everything after tedizolate, and think about those drugs that treat Pseudomonas. There are only a few actually in that section. Okay, so which of the following antibiotics does or does not have adverse reaction of photosensitivity? Now again, instead, guys, instead of copying everything or photographing, just think about it and remember the question and make sure you do, answer it, or you kind of listen and come up with a good idea. So what drugs come to mind that we remember with photosensitivity? What did you say? Macrolides, does everybody agree with macrolides?
No.
Do they have photosensitivity or not?
No.
If you clarify that, what you meant with macrolides. Is that your answer that you choose based on the question? Don't second guess, so think again. The question is, does not have photosensitivity. So what about tetracyclines? Yes, right? We want to counsel people on this. And that includes tigecycline. What about quinolones? Yes, absolutely. What about Bactrim?
Yes.
Yes. So which is not is the macrolides. So the macrolides do not cause photosensitivity, right? All the others do. So I highly recommend you guys to remember them. So now we have a culture and sensitivity report. Based on this, what can be inferred about the pathogen and the infections and the associated infection? So look carefully. Gentamicin resistant, clindamycin resistant, vancomycin susceptible, nafcillin resistant, ciprofloxacin resistant, levofloxacin resistant. So let's start with the one that is susceptible. What would that be? Susceptible to vancomycin. Is that a gram-negative organism? Would vancomycin treat any gram-negatives? No. So it has to be a gram-positive one, right? And which one? And then we look at nafcillin resistance. So what do you think is going on here? MRSA, right? It's most likely MRSA. And gentamicin, clindamycin, cipro, and levo would never treat MRSA. So that makes totally sense, right? That the organism is resistant to those. Okay, so we think it's MRSA. All right? Good. So now what's the option? The pathogen most likely is associated with a MRSA infection. The pathogen is most likely associated with a Pseudomonas infection. Would that be true? What would tell you it's not true? Look at vancomycin, right? If the organism is susceptible to vancomycin, vancomycin does not have any activity against gram-negatives, right? So it could never be Pseudomonas. It's most likely associated with a streptococcal infection. Could that be possible? Yes, it could be, because, but at the same time, nafcillin should actually be susceptible, right? So that should be an S if it's strep, right? Because Nafcin is a great drug for streptococci and staphylococci, non-MRSA, right? So that's a little bit more challenging here, but vancomycin definitely would treat strep, most likely Nafcillin as well, right? And clindamycin also. The pathogen is most likely associated with an anaerobic infection. Which drug would we look for anaerobic infection here? What's the only one in this list that would technically treat anaerobes? Out of those. What is it? Clindamycin, right? So clindamycin would treat anaerobes. So again, that is unlikely because the organ is resistant to clindamycin, so it's unlikely that it's an anaerobe, right? So based on all this, I think we can agree on A, that it's MRSA. Are you guys clear about this? Are there questions? Okay. Next question. What's the mechanism of interaction between quinolones and warfarin? I did ask you to look at the handout, right, that I had posted on Blackboard on the drug interactions with warfarin and I said you need to know the drug interaction between quinolones and warfarin. Does anybody know the drug interaction? What could it be? There's only a few mechanisms of drug interaction. What are the ones that you guys know from kinetics? Which one? Protein binding, and that's one of them, yes, right? So there is a IV protein bound. What's the other one? P450 is another big one, and there could be inducer or inhibitor, right? So that's always, it's mostly right, and that's also right. And then the last one, that the antibiotics do, all of them do something to your microbiome. We talked about this multiple times. What can they do? They did vitamin K, right? So they destroy the bacteria, the good ones that produce vitamin K, and that's another interaction. But that's for all antibiotics, right? So we have three mechanisms. What's the consequence? Protein binding, inhibition of CYP, and metabolism of warfarin and vitamin K. What do you think is going to happen with the warfarin? Higher bleeding risk, right? And what would happen with the INR? Increase, right? Increase. Okay, good. Please remember that. It's really important because you see a lot of patients who have a warfarin who may get prescribed a quinolone, and as a pharmacist, you need to tell them that, right? You need to tell them, watch for any signs of bleeding or have your INR checked, because that can happen within a few days, and it's very detrimental if that happens. All right. Next one, we have a physician who calls the pharmacy to find out about an appropriate antibiotic for a 6-year-old patient who has a respiratory tract infection. We just had a lecture on this. He gives you the following information. This patient is 6 years old, he has a penicillin allergy, and he develops hives, so a more severe reaction, right? Which of the following antibiotics would be most appropriate recommendation for this patient? So which one would you not give? Which one would you not give? B. And? What is doxycycline? A tetracycline. And what's the allergy against? It's correct answer. I agree with you, but I just want to, in terms of the yes. So we misunderstood. Yes, okay. It is a tetracycline, but yes, you're right. You would not give this to a child. So that wouldn't be a good choice. Augmentin wouldn't be a good choice. One more would not be a good choice. D, dicloxacillin, is another penicillin, right? So know the drugs. So which one is the only option here? C, azithromycin, macrolide, right? Okay, good. So next one, we have a patient who goes to the PCP with a respiratory infection. His provider decides to give the patient a quinolone. However, they would like you to recommend a quinolone that can be used in renal dysfunction as the patient's creatinine clearance is less than 30. Which of the following choices is a good recommendation? So let's start with E. Is E a good choice? What is this drug? Minocycline. Is it a quinolone? No, what is it? Cyclin. Tetracycline, right? So that's not a quinolone. Azithromycin, what is this? Macrolide, it's not a quinolone, right? Then we have levocetirizine and moxifloxacin, so 3 quinolones. Which one would be a good option? C, exactly. Respiratory quinolone, right? It's a respiratory one. So is levo, both of them. However, the main difference is it is hepatically eliminated. It doesn't go through the renal route, so it's a good choice for somebody who has a low creatinine clearance. And this patient doesn't have a UTI. Keep in mind, that would be not good, right? We just talked about this. So yes, that would be the good option. Levofloxacin could be given, however, the dose needs to be adjusted. So it's not totally wrong, but this would be a better option. Okay, which of the following antibiotics is or are especially important to monitor when a patient is taking concomitant diuretics and digoxin? Is it Bactrim, minocycline, lisinopril, ampicillin, or A and C? So let's look at this. If you think about ampicillin, is there anything that reminds you there is an issue with diuretics or digoxin? So any drug interaction that you can think of is ampicillin. Anything? No. Okay. What about linezolid? Did I say anything about electrolytes or cardiovascular drugs? Any? No, right? So A1C probably because he is here is already excluded. So we have minocycline and Bactrim. Which one do you think is the right one? Bactrim, right? So why Bactrim? So let's go back and think about digoxin. What's one of the side effects of digoxin? Or one of the mechanisms, I should say, that influences the activity of digoxin? Potassium, exactly, right. So it is potassium. So what did we say earlier about Bactrim? What's one of the side effects of Bactrim? Is, what does Bactrim cause? Hyperkalemia, right. And if we have hyperkalemia, what would happen with digoxin? Does it make digoxin more or less active? Less, right? So it would interact with digoxin, the potassium, right, the hyperkalemia. That and the diuretics on the other side would excrete the potassium. So there are multiple drug interactions, but we definitely want to monitor. We don't know which one is sort of predominant or not, but knowing the drugs, knowing the side effect, you automatically would monitor the potassium level in these patients. Okay. Which of the following is false concerning similarities between tetracycline and fluoroquinolones? Both classes have bactericidal activity. What did I say about tetracyclines? Are they bactericidal or bacteriostatic? Bacteriostatic, right? So yes, tetracyclines are bacteriostatic. So that's already wrong. That's already the wrong answer. So Let's look at the others. Both are susceptible to chelation by cations and must be separated from multivitamins and supplements. Is that correct? Yes. Both have activity against some gram-negative organisms. Yes. H-flu, for example, Haemophilus would be one. Patient taking either of these agents should be counseled about increased risk of photosensitivity. Yes, we already talked about. Okay. So, next one. A patient is admitted to the ICU with respiratory failure, heart failure, and acute renal failure. Has a history of COPD, diabetes, CAD, has a mechanical valve replacement, and has documented allergy to sulfur, rash and hives, and hydrocodone, nausea, and vomiting. On the first day of admission, the blood culture gram stains are positive for gram-negative rods. And the team puts the patient empirically on cefepime, metronidazole, and vancomycin. On day 3, the culture speciate to E. coli with these susceptibilities. So here's susceptibility here, E. coli. That's what they found. All right, and so, question. Based on this information, which of the following would be your recommendation? Keep in mind what the patient is taking. Cefepime, metronidazole, vancomycin. You want to continue the current regimen. You want to discontinue the vanco and metronidazole and continue cefepime. You want to discontinue his current antibiotics and initiate Bactrim. You want to discontinue his current antibiotics and initiate ceftriaxone. So critical thinking. First of all, when we had this regimen here, cefepime, metronidazole, vancomycin, what organisms were we treating? So what were we treating with vancomycin? MRSA. What were we treating with metronidazole? Some anaerobes. And what were we treating with cefepime? Broad. Cefepime. Gram-negative. Broad gram-negative. Very broad spectrum. All right, so we had basically gram-negatives, anaerobes, and MRSA. That's what we were thinking. So now, what is actually happening? We know it's E. coli, right? So do we have MRSA? No. Do we have anaerobes? No. So what would we do immediately? Discontinue what? Vanco and metronidazole, right? Now would you continue the cefepime? And now be very careful. I'm going to go back here. Cefepime is here, susceptible, but it's a very broad spectrum antibiotic, right? Very broad. It kills a lot of other organisms besides E. coli. What would be a more narrow option that we could give? Ceftriaxone, right? We could switch from cefepime to ceftriaxone to have a more streamlined, narrow. Definitely not meropenem, it's too broad. Pip/tazo too broad. The others are fine. What about Bactrim? Would that be an option in this patient or not? No, why not? Sulfur allergy, great, okay. So all of these are out. Now what about ampicillin sulbactam? No, there's no sulfur in there, no. So again, this patient, you could argue, you could say ampicillin sulbactam is an option, yes, we could do that, but that's not part of the question. So really the only answer here would be D, to discontinue the current antibiotic, all of them, and initiate ceftriaxone, right? Ampicillin sulbactam would have been an option, but it's not in the answer key. Is that clear? A question like this will be on the exam. So really, I highly, highly recommend you think about it. Think two things. A, what was found versus what was assumed to be causing the infection. And B, how can we streamline or direct the therapy without giving huge antibiotics for something that can be treated with a more narrow spectrum, right? These are the two important considerations. So we have a few GI and then I will be stopping. So we have this patient who comes with nausea, diarrhea, and abdominal cramps, a young person, and the patient has watery diarrhea in the past 10 hours. The symptoms started early this morning after attending a party at a friend's house yesterday where she enjoyed a yummy egg salad. The patient is otherwise healthy, but she has an allergy against macrolides, extensive rash. The PCP believed that it is likely food poisoning caused by non-typhoid salmonella. Which of the following treatment options would be most appropriate at this time? So keep in mind, what did I say to you about food poisoning? What are some key points of food poisoning? Key elements. Do we have self-limited? Good point. Next. A few other things. But there are two major types of food poisoning. It's watery or bloody diarrhea, right? So invasive, non-invasive. What about treatment in general? Do we always have to treat? No. Okay? So these are three major concepts. And if you have to treat, there's only two antibiotics that really can be interchanged, and fine. So in this, and then it also depends on the patient's risk factor. Immune suppression also, if there is a need for treatment. So this patient is young, has no other problem. It is watery diarrhea, and it is non-typhoid, which is the other thing for salmonella. We have typhoid or non-typhoid. So what would you do at this point? Start amoxicillin as soon as possible. Most salmonella species are highly susceptible to this. Is this correct? Amoxicillin, have I ever mentioned that as an option? No. Start a 10-day course of delafloxacin. Non-typhoid salmonella infections require antibiotic therapy, and this is an ideal drug to treat it. What is delafloxacin? What class is it? A quinolone, right? And what is specific about delafloxacin? It treats one organism very specifically. MRSA, right. So is that the situation here? No. So that would be very wrong, right? Azithromycin is a drug of choice for salmonella. This patient should be started immediately and continued for a total of 7 days. Is that correct? No. And the patient also has a rash to macrolides. Recommend fluids, diet, electrolyte replacement. In most cases do not require antibiotic therapy except in high risk patients. Okay, now if we had to treat, right, if let's assume we needed to treat this patient, what options would you guys recommend? What is one drug that is always correct? And I want to point out this one page here that was in your lecture, right? So what is one drug that is always correct, almost always? Cipro, right? Ciprofloxacin. So that would have been the right one. Azithromycin would have been fine too. So it's an alternative. So both of them would be okay if needed, right? Azithromycin or quinolones. Okay, good. So a few more and then we are done. So now we have a patient who has E. coli UTI. Has been treated with IV Cipro for the past 5 days, and they plan for a 7-day course. Today, on day 6 of the therapy, he starts having frequent loose stools that smell very foul. C. diff, PCR, and toxin tests have been obtained, and both are positive. As a result, he is diagnosed with C. diff infection. Pertinent information: he has a temperature, his white blood count is 14, his serum creatinine is 1.1. What do you recommend as the most appropriate treatment? So what type of C. diff does he have? Seems like it's the first one, initial episode, right? And what are some criteria? I give you some numbers here. What are some criteria that will help you to differentiate them? Yeah. So white blood cell greater than 15 or serum creatinine more than 1.5 or less, right? So that's important. So he falls into the category less. So that is what type of, what severity would you think? Mild C. diff, right? So initial episode, mild C. diff. Right here, if you studied, you should know automatically that's what it is. And then it would, in your mind, you should think about, before you even jump to the answer key, you should say, what do I remember about the treatment for mild initial episode? What is the drug of choice? Or the two drugs of choice? For mild initial C. diff. Biovenco, right? Or what's the other one? Haven't studied. Fidaxomicin, right? So we have two options. Both are drug of choice. How long would we treat for? What's this magic number? 10 days, right? I also told you to know the dose of vancomycin. 125 every 4 hours for 10 days. So these are the two options for initial episode 1. So let's see what the options are here. Discontinue the ciprofloxacin and start metronidazole 500 Q8 for 10 days, as this is a drug of choice for this type of C. diff. Now keep in mind, metronidazole is still possible. It's not the drug of choice. It is a possibility. It used to be the drug of choice years ago, but no more. So it wouldn't be totally wrong, but it is the word drug of choice should give it away. It is not the drug of choice. Okay. Finish the ciprofloxacin course and start fidaxomicin 200 milligram IV twice daily for 10 days, as this is the best option for this patient. What is wrong here? It's only PO, right, thank you. It's only PO, it's not IV fidaxomicin. Finish the ciprofloxacin course, start vancomycin PO, as this is recommended for this patient's mild C. diff. Or stop the cipro immediately and start vancomycin IV, as the patient has severe C. diff. C, right. You want to finish the course because, remember, the patient needs to be treated for the full course of UTI in order to treat his UTI, right? And he's already got 5 days, so he has 2 more days. Unfortunately, you have to treat them. If you stop now, you have 2 problems. This UTI is not completely treated. It could cause resistance or could cause longer complications. And there's nothing wrong to start the C. diff treatment at the time you still have the antibody. Of course, ideally you would discontinue the antibody, but there are ways sometimes we cannot do it. And that's one of them, right? You want to finish the course to treat the UTI and then start at the same time the C. diff treatment. Okay, last, I think, or second last. Unfortunately, this patient needs, so he's been treated. Unfortunately, the patient needs another course of antibiotics for a new UTI, which is treated with ciprofloxacin as an outpatient. 3 days later, he presents with foul-smiling diarrhea, white blood cell count of 11, and serum creatinine at 1.1. The PCP suspects another C. diff episode. Which of the following treatment options would you recommend at this time? So what is different here or what's not different? So what about the criteria for mild or moderate or severe? Is there a difference to the first episode? Only difference is the second episode, right? That's it. It's a recurrent C. diff. Other than that, it's the same. So is it again, this is a mild one. Again, another mild one. So at this point, if it's a recurrent one, we have various options. So you could either give, again, vancomycin, same course, right, as you did, or you switch to the other one, fidaxomicin. Or if you had started with fidaxomicin, you would switch to vanco. So you have an option, right, what to do. Metronidazole PO for 10 days, absolutely wrong, right? Definitely not. Vancomycin PO plus metronidazole IV. When would you use that regimen? Only. For which type of C. diff? Severe. Fulminant severe, right? So, yeah. Then you would treat with PO, IV metronidazole, and maybe rectal vancomycin, right? Yeah, so that's not the case here. Fidaxomicin for 10 days, yes. Bezotaximab for 10 days. Is that a treatment option? Yes, exactly. It has to be added. It's not an antibiotic, it's a monoclonal antibody, so this by itself wouldn't help. Now, doctors, the guidelines say you can give it in a recurrent C. diff, but it's very expensive. So usually they wait until we had at least maybe the second recurrence before you do this, right? Even so the guidelines say you can add it on, but it's not by itself an option. Okay, and then I have this other C. diff. More than one answer is correct. Is so. So C. diff is the most common nosocomial gram-negative anaerobic infection in inpatient settings. The use of PPIs is protective against C. diff as it inhibits the growth of the organism in the GI tract. Healthy individuals can be colonized with C. diff with no symptoms. However, the use of antibiotics can increase their risk for developing C. diff-related diarrhea, and fidaxomicin is a drug of choice for treatment of C. diff-related diarrhea. What is not correct? B, right? So these are risk factors. They are not protected, they're actually risk factors. What about A? Be very careful. What's wrong here? It's a compositive, right? Gram-positive, not negative. So that's a mistake. What about healthy individuals can be colonized? Yes, exactly. And fidaxomicin, the drug of choice. Yes. Okay. I think that's. I have one more about traveler diarrheas. We can just take a look at this. A young woman has hypothyroidism, is on levothyroxine. She comes to a travel clinic where you practice as a pharmacist. She told me that she is planning to go to Brazil during a spring break starting tomorrow. She went there in the summer and had to stay in bed for 5 days because she had very watery diarrhea that resolved by itself. She's only staying for a week this time, and she doesn't want to be sick again and anything ruining her drugs. She asked you if you can help her to get prophylaxis. So what's your answer? What did I tell you about prophylaxis in traveler diarrhea? Is this recommended for everyone? No. For whom is it recommended? For whom? Patients with risk, high risk, immunosuppressed, elderly people, and so on. So high risk patients. She is not. She's 25 years old. So the answer you will give her: talk to her. She should talk to her PCP, who should give her a script for an antibiotic called azithromycin, which can be used as prophylaxis. Educate her about prevention, which includes, and so on, gives you some idea, and tell her that antibiotic prophylaxis is not recommended in her case. Ask her to talk to her PCP, who will give her a script for a medicine called loperamide, which can be used to stop the diarrhea only if she experiences any bloody diarrhea. No, not for bloody diarrhea, right? It's fine for diarrhea, watery, it's fine, but not for bloody, which is invasive. Tell her that because she already had an infection in the summer, she's immune to the organism and will not have an infection this time. Totally wrong, right? Okay, so B would be the right answer. Okay, so I hope that helped you sort of cover the different issues. Right? I know you didn't study because otherwise you would have more answers. So really look at the practice questions. Keep in mind what you heard today, what we discussed.